Hi, I'm Dr. Christopher Bunick, Associate Professor of Dermatology and Translational Biomedicine at the Yale School of Medicine in New Haven, Connecticut. With me today is a dear friend and colleague, Dr. Naiem Issa. Naiem, can you introduce yourself for our audience?
Wonderful. Thank you for the introduction, Chris. So, my name is Naiem Issa. I'm a board certified dermatologist with Forefront Dermatology over in Northern Virginia, where I'm also the clinical director of clinical trials as well as academics for Forefront at large throughout the US. And I have various appointments and affiliations with the University of Miami in Miami, Florida, and George Washington University in DC, and West Virginia University College of Osteopathic Medicine. Happy to be here, Chris. Thank you so much.
No, thank you, Naeem. And so for our audience, we're here as part of the JCAD Journal Review program or series. And what we're going to be talking about is an article that Dr. Issa and I co-authored about tralokinumab as a therapeutic alternative for dupilumab-associated arthralgia in atopic dermatitis. And this was a multi-center case series. So, Dr. Issa, can I just start by asking you in general, what do you like about this paper and what are your takeaways from it in terms of the clinical aspects of it?
Sure. So something that is often not really discussed in the treatment of atopic dermatitis, especially when it's coming to biologic usage, and in particular with dupilumab, is having the arthralgia or arthritis. And mind you, so there has been some discussion about inhibiting IL-4 receptor and potentially leading to arthralgia and arthritis. But what do we do if that actually happens? Do we see any patterns there? Can we come up with any real world evidence or data that we can discuss with our colleagues and any find out any mechanistic approaches to see why this happens, right? And where do we kind of go from there, right? So we're talking about an inflammatory state, atopic dermatitis. We're treating that, but some of these patients get an arthritic kind of component to this. What the heck does that even mean? And this is why I like this paper that we come up with because it helps to answer that.
Yeah, excellent. You and I are, at least I think all of our colleagues and friends that know us would be considered science geeks, nerds, whatever you want to call us. We enjoy talking mechanism of action. And one of the things that I wanted to talk with you about is what does this article tell us about the mechanism of action of tralokinumab, or more broadly, for those dermatologists that are using biologics for treatment of atopic dermatitis? What does it tell us about the concept of cytokine skewing that can occur with some of these biologics?
Yeah, absolutely. So first, I always like to take a step back and give the lay of the land on how these medications work, because I still find that there's some confusion out there in terms of the MOA of these medications, right? So what we do know is that there is a big component of interleukin-4 and interleukin-13 signaling, right? And these cytokines have to signal through three main receptors, which are found on various cell types, including immune cells as well as your keratinocytes and your nerves and what have you, right? But it's a canonical signaling approach, right? You have what's called a type 1 receptor that is made of two subunits. Type 1 has two subunits, and this includes interleukin 4 receptor alpha, and you also have the gamma C chain, right? That's the type 1, and that's where interleukin 4 can go and bind. And then you go through and signal. Then you have the type 2 receptor right in the center here. The type 2 receptor also has two subunits, and that includes interleukin 4 receptor alpha and then interleukin 13 receptor alpha 1. And then interleukin 4 can bind and signal, as well as interleukin 13 can bind and signal. So there's a common pathway there for the two. And lastly, you have one more, I would say stepchild receptor that's hanging out on the side here called interleukin 13 receptor alpha 2. It's a single subunit. It's only one, right? It doesn't come in a pair. And only interleukin 13 can come and bind to it. And we're still not sure exactly what it does there, but it's termed a decoy receptor. But there could be evidence that it's doing something else, right? But it is still to be determined according to the scientific studies, right? So that's the canonical signaling pathway that we studied, in our textbooks, in our board exams, and what have you, right? Now, where do the medications fit into this mix? Number one, we have dupilumab, right, which is a interleukin 4 receptor blocker, right? Of the three medications that we're going to talk about, this is the only receptor blocker. So remember, you have your type 1 has two subunits, type 2 has two subunits. Both of them have interleukin 4 receptor alpha. So the antibody, which is dupilumab, goes and binds to that subunit, not allowing interleukin 4 to go through the type 1 receptor, and also interleukin 4 or 13 to go through the type 2 receptor. It's a receptor blocker, right? Then changing gears to the 13 cytokine blockers, all right? So you have tralokinumab and you have lebrikizumab. So imagine that this is interleukin-13 cytokine, all right? You have different epitopes. So when you're making a biologic, you can bind here, you can bind here, you can bind here, you can bind anywhere on the epitope. The choice of epitope is important because that dictates whether or not is the combination of the biologic with the cytokine, is it going to fit into the receptor even? Or can it fit and then not allow for the dimerization of the receptor? And that's two critical different outcomes between the two medications, right? So with tralokinumab, let's say it binds over here, I call it too fat to fit, right? You cannot fit it into either one of the receptors, all right? So there's no binding to the receptors. So tralo is too fat to fit. All right, that's the way I look at it. Then lebrikizumab is a little bit more lean. So it can bind over here, and let's say that, yes, it can get into the receptor, but the dimerization with IL-4 receptor alpha, it cannot happen. So while it sits there, it cannot close, and so it cannot cause signaling to happen. Two very different mechanisms, right? And so that can dictate the different outcomes. So we start there, right? So we understand the MOA of these medications, and then we try to see how does that fit to the clinical outcomes, to the potential adverse effects, right? So on and so forth. So now that we understand this, so your first question to me was, okay, what is potentially the immune phenotype cytokine skewing? Okay, so for those of you who are listening and are not familiar with cytokine skewing, you have your canonical immune pathways. You have T helper 1, you have your T helper 2, you have T helper 17, and over there in the distance, we have T helper 22, right? We're still figuring out what it may do in certain circumstances, right? And as we know that in your psoriatic diseases, you have T helper 1, that's your main thing. You know, Th17 is somewhere in the middle between the two. They can also have psoriatic disease, but could also be involved in chronic atopic dermatitis and some arthritides. And then Th2, which is the main attraction here, is what's involved with atopic dermatitis, right? And these other inflammatory disease states. So what happens is that either over time you can have a shift in that milieu from type 1 to type 2 to 17, or from type 2 to 17 or 1 or whatever, just as a natural course of the disease progression. Or when you're giving a medication, such as the biologics, what have you, you may be inadvertently shifting or skewing that immune phenotype. And that could lead to paradoxical psoriasiform drug eruptions, right? You can also have arthritides and what have you, right? So a main example, take dupilumab. Recall that dupilumab is an interleukin-4 receptor blocker, right? So what some of the studies have shown is that, first of all, interleukin-4 is necessary and sufficient to cause the revving up and development of the Th2 phenotype, right? You have to have interleukin-4 to activate Th2 from the naive T cells. Fine. However, if you're blocking the receptor for that, all right, you may be pushing interleukin-4 to cause the shift to the Th17 subtype, right? So there's some data for that, right? And then as we know, Th17 releases interleukin-17, which is found in some arthritides, arthralgias, and potentially psoriasiform eruptions or psoriasiform type of shift, right? Now, we shift toward the 13, right? So if you have the tralokinumab, which is an interleukin-13 cytokine blocker, but it's too fat to fit, right? You're just taking it away, taking 13 away, but letting 4 do what it typically does, right? So here, you may not necessarily be skewing the milieu. Fine. And we see that in our data. So we have this cohort of dupilumab treated patients, right, with moderate to severe atopic dermatitis that developed these arthritides, right? And then they switched to tralokinumab. And while they maintained or achieved skin clearance, their arthritides also went away shortly after, right? But then you have one interesting case in there. And we have one case, I believe it was even your specific case from your clinic, where you had a dupilumab experienced patient who had arthralgia, and then was put on lebrikizumab and also maintained arthralgia regardless, right? But then when they switched to tralokinumab, then the arthralgia went away, right? So there is some scientific data where lebrikizumab in vitro, remember, when you take the cytokine and lebri binds to it, it can actually go and attach to the receptor, but doesn't allow dimerization. The fact that lebri with cytokine goes to receptor causes it to be internalized. So the receptor and the receptor complex and subunits can all get internalized here. And so there's this theory that potentially the interleukin-4 receptor, that subunit is also internalized, thus allowing IL-4 to be more bioavailable to cause more skewing. So again, we haven't proven this, but clinically there may be some evidence for that, and it begs the question: is that truly happening, and should we study it?
So, Dr. Issa, with all that science, you really would be much happier if you came and worked in my laboratory. I'm just throwing that out there. The job offer. I think that what you said is incredibly important. I've always been a believer that science and mechanisms of action really the structural mechanisms of how our medicines work. Structure dictates function. That's always been an old adage, and it's true. Structure dictates function. And we're finding that more and more as we dig into how our drugs work. And that's been a real passion of mine in my lab. And I know it's a passion you and I talk about a lot. I
Mhm.
wanted to touch on one thing about the Th17 skewing. And
Mhm.
I think this connects a little bit of the dots because early on, when we talked about dupilumab and some of the side effects that some of the biologic patients experience, right early on, it's about conjunctivitis. The most common side effect that we talk about is conjunctivitis,
Mhm.
not the psoriatic arthritis type arthralgias, enthesitis, etc. But what we now know, a recent paper showed that there's Th17 skewing that's happening in the eye that may underlie that conjunctivitis. So the
Mhm.
same Th17 skewing that we're talking about and causing this dupilumab-induced arthralgia may actually drive some of that conjunctivitis. And I think that this speaks to the importance of better understanding cytokine skewing, the
Mhm.
phenotype changes that can occur in the patients, because we really don't understand why do some patients undergo this skewing and others don't.
Right.
And that alone is an amazing immunological question. Do you have any ideas on that?
So it's interesting. I think that kind of makes sense when you look at the incidence rates, per patient years of the long-term extensions across all of these biologics. So, granted, first of all, I will preface this by saying there are no head-to-heads, but you can start to see, like, if you're indirectly comparing these, right? You can see the rates of the conjunctivitis based and rank order them based on the MOA. At least that is my belief. Now, granted, again, it's not a head-to-head, so I will always say that. But you see that even with tralokinumab specifically over time, some of the latest data that I've seen is that the rates of conjunctivitis actually decreased over time with the longer term extension, which falls in place with that MOA, right? And so if you have the greatest amount of IL-4 being available in the milieu, right, through receptor blockade, maybe you're going to have more likelihood of skewing to the Th17. That could be involving the goblet cells and what have you in the eye, causing conjunctivitis. Then on the complete other polar end of the spectrum, right, you're not affecting the IL-4 milieu at all with tralokinumab. Well, now it starts to make sense to me why you're not seeing as much conjunctivitis. And then lebrikizumab is somewhere in between, potentially because of the downregulation of IL-4 receptor. So that logic or puzzle, if you will, makes sense based on MOA from what I'm seeing.
I agree with you. So just to mention that the case that we were talking about, dupilumab to lebrikizumab to tralokinumab, was Dr. Michael Cameron's case,
Okay.
and he was one of our guests on the JCAD journal review that we spoke to, and our audience can listen to that interview as well. But a very fascinating case, and I know that about a year ago or so, I started hypothesizing that maybe lebrikizumab had the ability to be an indirect IL-4 inhibitor and have some dupilumab-like properties. And I do think it's important that we continue to investigate and learn about these medicines. And in terms of head-to-head trials, I do want to mention you're absolutely right. In atopic dermatitis, among the biologics, we don't have head-to-head trials. What we do have are head-to-head trials between the JAK inhibitors
Mhm.
and dupilumab. In particular, there's been some trials with upadacitinib as well as abrocitinib, although there's some nuances between those trials
Right.
versus dupilumab. And we won't get into all of that data, but I mean, obviously, uh, the whole issue of JAK inhibitors versus biologics is an important issue about how it's elevating standard of care and all that type of new ways in which we're using composite endpoints,
Mhm.
skin clearance plus itch. Also, very, very important for elevating those standards of care for atopic dermatitis. But when it comes to the biologics and the trials and the lack of head to head, it does it makes us as clinicians rely a little bit more on real world evidence. And so, two pieces of real world evidence. You mentioned the tralokinumab. There is a new real world paper, real world evidence paper out on tralokinumab that I think highlights what you said about conjunctivitis, where compared to the real world study on dupilumab, I think there was like 20% reduction in conjunctivitis rates
Hmm.
between those two real world studies. And then secondly, just to stay fair and balanced,
Hmm.
there even though this paper did focus on dupilumab to tralokinumab switches, and these patients did incredibly well that had this arthralgia and it sort of disappeared. And remember, these patients, it wasn't just the joint pains going away; their skin was clear and their itch was very good. These patients did very well overall. And that begs the question, do patients that have this arthralgia on dupilumab, is there something about that particular phenotype or endotype of patient where they're going to respond really well to some type of IL-13 blockade? A question there. But there are anecdotal cases talking to our colleagues of JAK inhibitors also reducing dupilumab-associated arthralgia. Have you encountered that? What have you heard from our colleagues
Yeah,
about JAK inhibitors reducing arthralgia?
yeah, I think that makes total, mechanistic sense. And I do see that myself. And also, like, just a point is that JAK1 inhibition, for upadacitinib specifically, there is an indication for psoriatic arthritis too, So if you keep that in mind in the background, right? So yes, it does make sense because, first of all, these. The JAK signaling, specifically JAK1, right? It's the nexus, right, of all of these cytokines. And we haven't even talked about TSLP and interleukin 22 and what have you. But all these puppies have to go and signal through that, right? And so I see how that makes sense because you're blocking any excessive signaling from one cytokine component or another, irrespective of what the cytokine actually is, right? You're here, you have a totally different direction here. You're hitting the nexus. And on top of that, I personally believe that given the pharmacokinetics of JAK inhibitors, whatever it may be, right? That it's short half-life and that short K on K off, right? The binding and the disengagement from the JAK itself. You're not giving the proteins enough time to be internalized or to be, turned over or to even allow for skewing. I haven't seen skewing with the JAKs, personally, but in your experience, are you seeing any immune system skewing with JAKs?
I have not seen that with any of the JAK inhibitor patients that I have. So it raises a really good question. I think that this is, again, another area where the JAK inhibitors have really transformed dermatology, not just in atopic dermatitis, but in a lot of diseases over the last 2 to 3 years. One of the things that you mentioned was the indication of upadacitinib for psoriatic arthritis. That's a really key point. I don't think a lot of dermatologists realize upadacitinib, amongst many of its indications, I think over double digits at this point. People don't realize psoriatic arthritis. I actually have psoriasis patients with psoriatic arthritis that have not done well on any of the biologics. Switch over to upadacitinib. Do you
Mhm.
have any psoriatic arthritis patients on upadacitinib?
Yes, actually, and then somehow sometimes I find some psoriasis on them as well, and these I have some cutaneous psoriasis where I've had these recalcitrant patients who have been on like methotrexate or azathioprine or whatever, right, or on TNF, and I put them on and it's been wonderful. But as we're moving away a little bit from the main concept for today's JCAD journal venture here. But I think the main point is, again, we're science nerds. This is what we love, right? The point is understanding mechanism of cytokine signaling with these disease states, what's in common, right? And just how that all plays out really dictates the outcomes, don't you think? Because you can predict the outcome. If you understand the mechanism, you can totally predict the outcome every single time, right?
So, Dr. Issa, one of the things that I would say is people may be listening and say, okay, I've been using biologics. I'm now using some JAK inhibitors too. I know about all of these medicines. Why does any of this matter? Well, I think the reason it matters is because there's over 20 biologics, bispecifics and trispecifics in development. That's
Mhm.
not even including just half-life extension technology and other technologies. We're
Mhm.
talking like an onslaught of innovation in atopic dermatitis. And so understanding the mechanisms of the six currently approved medicines, the two JAK inhibitors and the four biologics, is incredibly important because we're about to get a mix mash of all of them
Right.
fast.
Right, right. And we're in the golden age of atopic dermatitis specifically. At least I would call it that with the development of all these medications. But one key thing is that for those who are not focusing on demographics of the trials, all right, this is something that gets lost in the shuffle, right? Is that yes, we have awesome MOAs, right? We're coming and we're going to study this and we're going to probably hop on in another year discussing the new MOAs together, just like this. But the phenotype of the included subjects has changed, right? For if you think back to the first dupilumab trials, right, a couple of years back, these were biologic naive patients, correct? You had different pollution factors depending on where they are, right? Different exposures, different medications that they were on in the past. So that phenotype is so different than a tralokinumab study where they even had about 5% of patients were previously on dupilumab, right? Totally different immune skewing by the time they even got in the trial. Lebrikizumab, whole nother story, right? As we are progressing with clinical trial development, yes, we're going to have like these tri-specifics that are hitting TSLP, interleukin 13, and interleukin 4 at the same time. Yes, we're going to see some great data out of it. Like, of course, we predict all that to happen. But how is it translating to exactly the kind of AD patient that we're seeing in front of us? Especially with patients, and mind, this is something that we barely talk about. You have a TSLP inhibitor, right? I believe it's called tirzepatide, right? That is for asthma, right? So you have your allergist using a TSLP inhibitor that is going to also skew the phenotype before they even get to the dermatologist if they have the atopic triad. So the landscape is changing so rapidly, right? And we have to keep this in mind as we're interpreting and knowing how the MOAs play out for the specific patient. So I think we're going to get into more precision medicine.
Yeah, I mean, I agree with everything you just said, and it is incredibly tricky as we understand these medicines more and more. It is essential because one of the things that I've observed, and goes along with what we're talking about, is that in the data of all these biologics and in the JAK inhibitors, what you see in the trial data is that the bio-experienced patients generally are a little bit tougher when you switch over, which whether it's a biologic or a JAK inhibitor, how you're switching, right? And certainly, I don't think you and I are big proponents of biologic cycling over and over, but the point being that no matter how you're switching, generally the bio naive patients tend to respond better than the bio experienced patients. And that does suggest some type of immunological consequence or memory based on whichever therapy comes first. And
Mhm.
how that plays out in subsequent therapies is an incredibly interesting immunological question.
Absolutely. Absolutely.
So I want to end, Dr. Issa, by coming back to where we were, talking about a paper where we have dupilumab-induced arthralgia, a series of patients, I think 15, that switched to tralokinumab, did incredibly well, resolution of the joint pains, skin and itch did very well. But what, to me, the core fundamental thing is clinically, we just have to ask our patients the question, are you having joint pain? We don't generally ask our atopic dermatitis patients that. So if you could give our audience a final message, clinically, what do our colleagues need to be asking their patients?
You have to be holistic in your approach, right? As dermatologists and dermatology clinicians, right? We're beyond skin, all right? So we're more than just skin deep, right? So you got to ask for these symptoms, right? Because sometimes your patients may not even realize as that their disease state that's doing this. Could it be a medication that they're on? You got to be holistic. It takes 2 seconds, right? And ask them about joint pain or just joint discomfort, right? And then you will elicit an answer from that.
Excellent. Dr. Issa, thank you so much for joining me. And thank you to all of our audience for participating with us in this JCAD journal review. Thank you.